Good Good afternoon, everyone. My name is Kate McGrail, and I'm a member of the Community Health and Wellness Division at Suburban Hospital. We're pleased to have you here for today's program, Precision Medicine and Alzheimer's Disease, the right treatment at the right time. We last met in March to talk about lifestyle factors affecting Alzheimer's disease. And before that, in May 2023, to learn about recent advances in Alzheimer's disease. Collectively, we've reached over 230 of you on this topic, and we're so glad that you're re-engaging with us again to dive deeper into a new aspect of this topic that we hope will not just teach, but empower you. The evolution of technology in medicine has expanded the treatment options for those with Alzheimer's disease, or AD. To harness the power of precision or personalized medicine, we must first understand the distinctions between the types of brain disease, of which AD is just one of a multitude of disorders. Our guest speaker, Dr. Lekestos, will lead us in a conversation to help us better understand the difference between dementia and AD, biomarkers and how they aid in a more accurate diagnosis, and the definition of precision medicine and how it is utilized to identify patient-specific approaches to Alzheimer's care, treatment, and prevention. We've expanded the allotted time today, leaving ample time for you to ask your questions that will support your understanding of this disease as well as personal wellness. Okay, so just a brief overview of what we'll be covering today. I'm going to go through a few housekeeping items first. So this recording, or today's session, is being recorded, and we will share it with everyone who is registered. And at any time you would like closed captioning, there is a bar that's with the letters CC that you can click. And that's on the bottom of most devices. And because we're using Zoom webinar today, you will remain on mute. We highly encourage you to remain interactive with our speaker, so please feel free to use the Q&A feature. So that's different than the chat. You can put your question in the Q&A icon at any time, and our speaker will respond at the end of the session. If you'd like to practice, you can type yes right now if you've joined in any of our other Alzheimer's topics with Dr. Albert in March or May of 2023. And you can type no if this is your first time joining us. That's just if you want to practice using that feature. And lastly, the programming we offer is highly driven on your feedback. We kindly ask that you take a moment at the end of today's session to complete a short evaluation. And that form will pop up on your screen at the end of the session when you hit the red leave button. If you're unable to complete the survey today, we'll send it with the recording by the end of the week, as well as a link to the recording. And so now I want to just take a quick moment to talk about Suburban Hospital's Village Ambassador Alliance. Did you know that the U.S. Census Bureau predicts that by 2035, the number of adults greater than 65 will outnumber children in our country? Oops. With this tremendous advancement in medicine, we are all living longer, but we also want to live better, of course. So in a moment, you will hear more about the local village partnering with this event. But at Suburban, we have an initiative that is very much aligned with the local village movement. And that is our desire to keep older adults not just living, but thriving, independent, and empowered. Seminars such as these are just one example of how we can support these goals. We are so proud to have invested over $15,000 over the years empowering villages to make advances in aging at the neighborhood level. And now with that, I'd like to turn it over to Ms. Connie Rao, the president of the Friendship Heights Neighbors Network.
Good afternoon, everyone, and welcome all of you from all the various villages. Um, well, I'm so glad that you're attending this session. Our network is in Friendship Heights, and as I was just explaining, has a very high proportion of people who are in the age category most affected by dementias and Alzheimer's and the rest. So we are especially interested in this topic in our village, but villages generally support seniors who want to age in place. There are 30 of them in Montgomery County, another 10 or so in the district, and more in Northern Virginia and across the country. To that end, we all try to provide programming both on social and cultural topics, but most especially on healthcare, including topics like this one that will educate everyone and keep us abreast of what the changes are that we need to be aware of. So I'm so proud to be partnering with this. This is also a collaboration with Little Falls Village, another village that is adjacent to us. That is part of our collaboration. But I want to also make sure that all of you know about the partnership and its importance from Suburban that has provided the programming that otherwise we would not have available to us with the speakers, with the past speakers, and with the speaker today. So I want to thank all of you, thank Kate, thank Costas, and thank all of you for coming.
Thank you, Connie. And now I have the honor of introducing our featured speaker, a native of Athens, Greece. Dr. and Professor Lekestos graduated from Northwestern University with a BA in psychology and from Washington University Medical School in St. Louis with a medical doctorate. He completed residency and chief residency in psychiatry at, our favorite, Johns Hopkins, as well as a fellowship in clinical epidemiology. As an active, we're going to go to this page for you, Dr. Lekestos. There you go. As an active clinician, teacher, and researcher, Dr. Lekestos is a world expert in the care and treatment of patients with Alzheimer's and related dementias. He carried out pioneering work on the epidemiology and treatment of neuropsychiatric features of AD. His team is developing biomarkers to accelerate treatment development for AD while designing and implementing innovative clinical trials. He leads efforts to ensure the provision of state-of-the-art dementia care for people with dementia in the community. Dr. Lekestos is the Elizabeth Plank Althouse Professor at Johns Hopkins University. He directs the Johns Hopkins Bayview Department of Psychiatry and Behavioral Sciences, as well as the Richmond Family Precision Medicine Center of Excellence in Alzheimer's Disease and the Memory and Alzheimer's Treatment Center. He is the recipient of multiple awards, including the 2022 Argo Award for Science from the President of the Hellenic Republic. He has authored and co-authored over 450 peer-reviewed articles, chapters, commentaries, and 5 books. His work has been cited over 76,000 times with an H index of 149. He's a 2021 Stanford University publication reported that he ranked 13 out of 9,246 scientists worldwide in the field of geriatrics. We are so lucky to have Dr. Lekestos and his wealth of expertise in this field joining us today. Thank you, Dr. Lekestos. And I'm going to unshare and turn it over to you.
Kate, thank you very much. I wonder if the blushing was showing in contrast to the sunrise, the sunset that's behind me. It truly is a pleasure to be here. I want to thank Kate and Connie for the introduction and certainly for inviting me. I'm always excited when I talk to people who are not necessarily health professionals because we always get into very good conversations and discussions, and I think that's very much my frame of mind right now. So I'm going to pull up my slides. Goodness, what do we have here? So now I have to find the right slides. Can you see them?
Yes.
All right. So I will talk about precision medicine, but I'm going to do it in the context of where we are now, where we've been recently in the broader Alzheimer's field, and talk about how precision medicine is entering our thinking, both in day-to-day practice, but also as a pathway for future success. So I think there are 8 issues on the topic. I'm going to cover each one of these, but I like to give people take-home messages. So these are take-home messages. You'll see them again at the end. Pick on one or both of them, one or more of these, or all 8 if you wish. I'm going to define dementia in contrast to Alzheimer's disease. I hope that you're able to walk away with a better understanding. I'm going to very briefly tell you why dementia is the next pandemic. It's not an infectious disease pandemic, but the numbers are increasing dramatically all over the world, and that's why it's a pandemic. I'm going to differentiate dementia from Alzheimer's, partly by making the point that a diagnosis of dementia is highly accurate. We're very good at making that diagnosis. Whereas the diagnosis of cause of dementia, and I'll explain what I mean in a moment, is where this whole new field of biomarkers is coming into play. And I'll be telling you what biomarkers are, what we have available, and what we expect to see. I want you always to remember, in the context of this environment, that we do have an approach to comprehensive care. Much of it was pioneered at Hopkins over the years. We call it memory care or dementia care. It's quite effective. It doesn't cure dementia. It doesn't reverse it. But as you'll see, it has huge benefits to patients, family members, other caregivers. And so there's hope. Even if we don't have a cure, we definitely have hope. And this is starting to come to a neighborhood near you through an innovative payment model called Guide. And we'll come back to that. Guide is going to launch at Hopkins next July and is going to be a home-based care management way that Medicare pays for to help people and caregivers living at home. I'll go then more on the side of precision medicine, talk about the novel medicines that you may well have heard of. And I'll touch upon the possibilities of prevention. I have a handout. I'm realizing, Kate, that it's embedded in my slides, but it's a one-pager that everybody can have as a PDF. So maybe I can work with Kate afterwards to make it available to everyone. And then we'll talk about precision medicine, and you'll see precision medicine woven throughout this presentation. If you have a question anywhere along the line, if you don't mind, put it in the chat at that moment. That way we won't lose track of it, and want to make sure that stuff that you have questions about early in my talk also become addressed. So, issue 1, definition, dementia versus Alzheimer's. We all know that as we age, there's some cognitive decline. We call that usual cognitive aging. I don't like the term normal cognitive aging because nobody's normal, but this is what we see that's usual that happens at a population level. It's important to appreciate that in this day and age, and for quite a while now, we're very good at knowing how much cognitive change can be attributed to aging. And that becomes very important because when I see a patient with a memory complaint, the first question I have to answer is, am I dealing with usual aging, or has the person fallen off their personal curve? They've been in the 50th percentile all their life in terms of cognitive performance. Are they now coming below that, the 30th, 20th, or 10th percentile? And it's when people fall off their personal curve of their usual cognitive aging that we start getting concerned about a cognitive disorder. There are 2 kinds of cognitive disorders. One are what we call the prodromal states. We call them prodromal because they happen before the bad state, which is dementia. So mild cognitive impairment, mild behavioral impairment, these are changes in cognition, functioning, or behavior that are not explainable by aging, but are not severe enough to really impact on day-to-day function. People can largely still live on their own, even though these are noticeable changes. Dementia is the next stage. Dementia is when you have cognitive or behavioral change combined that is now affecting your ability to function independently. If you're in your 50s, maybe it means that you can't work. If you're in your 70s or 80s, maybe it means you can no longer drive, handle your medications. And in severe cases of dementia, it might mean that you can't take care of yourself in a very effective way. So these are all clinical states. Deciding whether someone has usual cognitive aging, whether they have functional disability, or whether they have dementia is something a good clinician can do in a relatively short time frame. That's what dementia is. It's the clinical condition. On the slide, though, you see Alzheimer's here, and this is the brain disease. What's in the brain, Alzheimer's is only in the brain, and we see it based on certain studies either after death or during life with these biomarkers that we'll talk about. So the difference is really illustrated by this addition to the slide. Dementia, MBI, MCI, those are all clinical states that we can measure in the hands of a good clinician very accurately. But what we are in the past couldn't do is look inside the brain and see what is going on that is causing the dementia. And that's where we find diseases like Alzheimer's and Parkinson's disease and a variety of others, because now we can recognize the way they have affected the brain. So this is the next pandemic because on a worldwide basis, we have a steady increase in number of people. These aren't percentages. These are numbers of people. So if you just look at the Americas, and that's North and South, 2015, the estimate was that we were dealing with about 9 million people alive with dementia. Every 20 years, that is roughly doubling. So the projection for the Americas, unless something changes, is we'll have close to 30 million people alive. Those same estimates on a worldwide basis, 2050 will get us at 131 million. 2030 is not far, folks, and already we'll have the first doubling by 2030. Now, why are we so concerned about this? Well, because dementia is, generally speaking, a 10-year illness. And people increasingly need others to help take care of them for the majority of that time, whether it be very simple care support or something more elaborate, which is much more hands-on. So you're really talking about a 10-year illness in the worldwide basis in 130 million people, 10-year illness with a couple of other folks affected. So you quickly get to 500 million people in 2050 are affected on a daily basis by living with dementia. That's why it's the next pandemic. And that's why we are, in my field, trying very hard to prepare foundationally so that in the US and certainly in Maryland and in our immediate central Maryland have the ability to take care of people who have dementia. So the point I'm going to make over and over again, how do we make the diagnosis? Well, the diagnosis of dementia is quite accurate. We can make that diagnosis with a standard clinical history and using a bedside, as we call it, memory scale. In this case, I'm showing you what's called the Montreal Cognitive Assessment. This was popularized several years back by the previous President Trump. We have a new one coming in, I understand. So the previous President Trump had a MoCA test done when there was a concern about his cognitive functioning. And that is the appropriate test in many cases if you're worried about whether someone has dementia or not. This is part of a clinical package. But again, I'm illustrating that with the MoCA, Montreal Cognitive Assessment, the history, information, of physical exams, and basic lab studies, we can decide if someone has dementia or not. Well, what about the cause? Because if you have dementia, there's something in the brain causing it. What could it be? And this is where biomarkers will come into play. Here's an example of one biomarker. These are PET scans. I'll talk a little bit more about what they are. But for each disease that we're talking about now, increasingly, we have biomarkers. We have good biomarkers at this point for Alzheimer's disease, so we can measure the brain disease through various ways. We'll come back to that. We're getting them for Parkinson's and related conditions and so on and so forth. So clinical state, we're very good at. Cause we're working on, and we're getting better because of these biomarkers. So what are the major causes of dementia? Well, there are over 80 proposed causes: thyroid loss, brain cancer, a variety of other conditions can cause dementia. But for all intents and purposes, in the US healthcare system, those conditions get caught early and treated before the person gets dementia. When I was coming through medical school in the 1980s, we occasionally would see people with vitamin B12 deficiency or severe hypothyroidism who had dementia because of that, and treating the thyroid problem or the vitamin B12 problem would generally solve the condition, at least stabilize that. We rarely see that now. Most of the time, what we see are these four constellations of conditions. One is Alzheimer's disease. We'll get into that a little bit more. The other are referred to as the Lewy body diseases. That's Parkinson's and its cousins. They're called Lewy body diseases because there's buildup of a certain protein in the brain called alpha-synuclein. Then we have frontotemporal degeneration, a set of conditions that cause dementia, usually in somewhat younger people in their 50s, 60s, occasionally their young 70s. Very different clinical picture, very different cause. No great biomarkers for that quite yet. Of course, there's brain vascular disease. If you have a lot of strokes, you can get dementia from that. But we're also appreciating that as our MRI tools get better, we can see microbleeds, teeny little dots that are multiple little strokes that the person had no idea about that can cause or contribute to dementia. And we're also recognizing that as we get older, many of us have insufficient blood flow to our brain. That's not something that moment to moment will create a problem for us, but over time it accumulates. So it's a little bit like starving different parts of the brain periodically, and the minor injuries that causes build up over time. And we think that that can either on its own cause dementia or trigger some of the other conditions. So if you have chronic brain vascular insufficiency, maybe you're more likely to have Alzheimer's pathology as well. You also want to appreciate that age matters. So younger people who present with dementia, and by younger I mean 60 and 70-year-olds, typically have one pathology. But as you get older, in 85, 90, and the few 100-year-olds that we see, they tend to have mixed. They might have Lewy body and Alzheimer's, or vascular and Alzheimer's. So tends to be more of a single cause in younger people, and you have an accumulation of additional causes in the older people, which make it much harder in 90-year-olds, for example, to be very effective in getting rid of the primary brain disease. That's all I'm going to say about pathology outside Alzheimer's, but I now want to talk a little bit more about Alzheimer's, and I mostly want to do that so I can link it with some of the biomarkers. So many people over decades have studied the brains of people who passed with Alzheimer's and donated their brains to be studied. And that has allowed us to get an understanding of the pathology, what is going on in the brain. And there are three general changes that we see. I won't get into them in great detail, but we could in the Q&A. So the one is you see this word amyloid here, and it refers to this big red glob. And you see in the big red glob, there are little pieces of spaghetti floating around. These are what's called A-beta fragments. That's amyloid protein. A-beta is produced in millions of molecules every day inside our bodies through our brain cells, and it's usually thought of as a waste product. But as we get older, these little strings of A-beta, especially A-beta 42 chain length, builds up and over time will start coalescing into a plaque, which is what you're seeing here, this big red glob. So again, you're seeing the little A-betas form and float around in the brain, and over time they start to connect to each other and form small constellations of 2, 9, 10, 15 little strings, but then they can form this plaque. And there's this constant equilibrium. So the production of these little single fibrils, as they're called, all the way to the many fibrils, all the way to the plaque. We think, and this is what we call the amyloid hypothesis, that the creation of these fibrils in the plaque is a major driver of why people eventually get symptoms. Well, how does that work? Many ideas. Some of them seem pretty well supported. One is that these start affecting synapses. So here you see brain nerve cells. They have a cell body, and then they have a synaptic bouton. And down here to the right, you see the next nerve cell. So these two boutons are supposed to be next to each other so that this nerve cell can signal, release its chemicals, and the downstream nerve cell can get information, and that's really how the brain works. So I think you would appreciate that if you're starting to physically affect this connectivity, then you're going to start having problems in the ability of the brain to function because the signaling doesn't pass down. And over time, we think that once this process with the plaques begins, inside the nerve cells, you start seeing these little helical filaments. These are what's called hyperphosphorylated tau. So you will hear a lot about amyloid, and that's the fibrils in the plaque. And you will hear about tau, which is tau is the protein that holds the axon and the nerve together. It's like the mortar to the bricks of the structure. If tau starts getting phosphorylated, it's not very good mortar. And so you start having very bad dysfunction inside of the nerve cell. And eventually this nerve cell will die. So that's the third hallmark. You have the plaque, you have the tau, and the death of the neuron. You will also see around here these evil eye-looking little structures. These are supposed to portray inflammatory brain cells. They're called microglia, and they are involved as well, but we need a lot of time to sort of think through how all of these are involved. So I'm showing you a snapshot, and one of the challenges that science in this area has had for a while is figuring out the sequencing of all this stuff. We've studied people with milder and milder symptoms, we've appreciated that it's not all there at the same time. And therefore, we have created what's known as the amyloid hypothesis, which hopefully I can show you the next slide. And the amyloid hypothesis very simplistically says, and we'll come back to that, that you have the A beta 1 to 42, those little fibril stringies. They start accumulating, they do their thing that we are more and more understanding. Then inside the nerve cells, you get the tangles, you get neuronal loss, you get loss of circuits, and ultimately when the brain, which is a series of circuits or networks, you start losing the circuits, that's when you start getting symptoms. So this is an interesting idea that we've had for a while, and because A beta 1 to 42 is at the top, the effort has been to get rid of the A beta 1 to 42 with the view that this is going to help people. We'll come back to where we are with that idea and how successful we've been. This also illustrates for you the concept of what do we need biomarkers for? So now I have someone with mild cognitive impairment, MCI, or dementia. How do I know whether they have oligomers or tangles or neuronal loss or circuit loss? So this is where biomarkers come into play. They start telling us different parts about where this person's brain is in relationship to this cascade. So we have biomarkers for amyloid. We now have biomarkers for tangles. We have biomarkers for neuronal loss, pretty soon for circuit loss, et cetera. So in a given individual, we're getting better at staging if they have the Alzheimer's process going on in their brain and how far along that process is in this cascade. So I'm noticing the questions, and I'm glad to see that some of them are being addressed live. Okay, so let me talk a bit about biomarkers. So the first biomarker that's been around for a while is using a brain MRI that you see here. And brain MRI now is very good at precisely measuring the volume of different brain structures. And with regard to Alzheimer's, the most interesting structure is called the hippocampus. I don't know if you can see, it's right here. This gray little structure here in a healthy person looks pretty normal. In someone with Alzheimer's disease, there's nerve cell loss, and you see the hippocampus in this Alzheimer's person is very small, and there's big black hole next to it, which is full of fluid, which is where the hippocampus was until it started getting shrunken. So here's a biomarker for the neuronal damage that we were talking about a second ago. And it's for a particular brain region that is directly relevant to Alzheimer's. For brain autopsy studies, we know that the hippocampus is one of the first places to go, so to speak, And we have this biomarker. We've had it for a while. And so if someone is being worked up for Alzheimer's, they might be advised to have an MRI with a process called neuroquant, which is the digital measurement of the size of hippocampus. We can actually measure the size of many other brain areas quite accurately in the same process. We're still not to the point where we know what to do with that information, but that will come, and that's going to speak more to the concept of losing networks. So here's a biomarker of neuronal loss in the hippocampus, and here's a pathway to precision medicine because it's telling us people who have abnormally shrunken hippocampi are different from people who don't have abnormally shrunken hippocampi. So let's talk now a little bit about PET scans. So all of you are familiar with X-rays and CAT scans. And these are basically procedures where you put someone in front of X-rays, and these X-rays pass through the body, and the way they scatter on the plate that's behind them gives us some information. A CAT scan, you do that in a big donut tube you're sitting through. The machine is sending X-rays through you, and the X-rays are then the scatter is registered on the other side of your body. Well, a PET scan is an important variation. So in a PET scan, instead of having machines send X-rays through you, what is done is that you are injected with a molecule that has a little bit of radioactivity. And so now the X-ray equivalent, the positron emission tomography is what PET stands for. So instead of looking for X-rays, the machine is looking for positrons. And it allows that to then see where is that radioactive molecule in your body. So that allows us to make many different kinds of radioactive molecules. PET scans are used very often in oncology to find where metastatic tumors might be. In that case, they label glucose, sugar. But in the Alzheimer's field now, we can label molecules radioactively. And I should say, it's very brief activity. It washes out of your body pretty quickly, and it's not really dangerous to you at that level. But it tells, so if you make a molecule that will go and stick on amyloid for a brief period of time, you can see where the amyloid is and how much you have. So here's an example of a PET scan, and often PET scans, you want to think of blue as good and up through green and yellow into red is worse, if you will. So this is a scan of this individual's brain up here, showing us where they have amyloid. We don't expect there to be amyloid. So you can see, for example, this part of the brain is kind of light green, bluish. There's hardly any amyloid, but you see a lot of red here. So now we're imaging the amyloid in the brain using a PET scan. And that gets quantitated in very good ways, is used in studies. We'll come back to that, et cetera. But the biomarker here tells us the amyloid. We are using this day to day in clinical practice. If someone comes in and we have a suspicion for Alzheimer's disease, we might order an amyloid PET scan. You might say, well, what about tau? Well, in fact, we can also measure tau. And you can see the distribution of tau here is quite different than the distribution of amyloid. And we have come to expect that based on what we know from autopsy studies. So here's another biomarker that tells us how much tau one has. This too is FDA approved. Still unclear whether, it's pretty recent, it's still unclear whether Medicare will pay for you to have a tau scan. It's going to be important, we think, in the near future that they do as part of the new therapeutics that we have in our hands. So if someone comes in with dementia, we now have these tools using brain imaging to understand how much amyloid, how much tau, how much neuronal loss they have in their hippocampus, and it helps us therefore stage the brain side of this equation. Now you might say, do I really have to have a PET scan? Is there no other way where you can get this information? And the answer is, well, ultimately PET scans are the gold standard. They're very useful in research, but in clinical environments, we don't necessarily need all the information in the PET scan to make our clinical decisions. So we are increasingly relying on biomarkers that come from body fluid. So if there's a woman who gave birth to a child and had an epidural, or there's a man who might have been with a spouse who is getting an epidural, you will appreciate that we can now get CSF. It's very similar. The needle in the back. In the epidural, the intent is to put anesthetic around your spinal cord so that you are relieved of pain. In this case, though, rather than put in a medicine, we take out some fluid. That fluid is called CSF, cerebrospinal fluid, and it's sent to a lab and it's analyzed. And it's possible to measure, guess what? Amyloid, tau, and a variety of other biomarkers. So with a CSF study, we actually get very good biomarkers for Alzheimer's disease, and we hope eventually for other conditions. But we don't have the location information that we get from the imaging. The imaging tells us where's the amyloid. This just tells us that there's a lot of amyloid above a certain cutoff. So there's amyloid and it's not good. But you might say, well, do I really have to have a lumbar puncture? I mean, I've got to go see my friendly neighborhood neurologist and I've got to sit still for a while and I might get a headache. Pretty routine, but it's pretty invasive. What about blood tests? And the answer is, yeah, we're getting there. So we now have a variety of blood tests that I'll just really briefly touch upon. These are literally of this past year in terms of their availability, but more importantly of insurance payment. They're not very expensive, and they are slowly factoring in as biomarkers that we will use. So these biomarkers use, a methodology, for those of you who are technically inclined, something called mass spec. Mass spec can measure in the blood the A beta 40 that we talked about, which is, if you will, the good A beta, the A beta 42, which is, if you will, the bad A beta, allows us to do a ratio between 40 and 42, and p-tau 217. And don't worry too much about the graphs. These are just giving you an example that the amount of p-tau 217 in your blood and the ratio of A beta actually is a really good indicator as to how much amyloid is in your brain on a PET scan, and also how much tau there is in your brain on a PET scan for tau. So they have issues, but they have the appeal that they are inexpensive and easily accessible, so they're slowly finding their way into day-to-day practice. Let me underline that these are not appropriate for someone who is not diagnosed with MCI or dementia, because we really don't know. And we're seeing some folks coming to us who are perfectly healthy 80-year-olds, some physician well-meaning, found that they have an elevated one of these biomarkers and they don't know what to do with it. And neither do we, because the test is being used in a setting that it's not ready for. Maybe in the future it will be, and it'll be useful information. So I just want to underline that. These are easy to do, they're inexpensive, but it's got to be really careful with how they are used. So let me keep going. So I just want to very briefly remind you what I was saying earlier. We do have a way of taking care of people right now. We wrote the book about it. You're welcome to it, but it's really written more for professionals. And there's really a package of things that we do. We make sure that people are on the currently FDA-approved medicines like the Nepazil, known as Aricept, or galantamine, Razidine, or rivastigmine, Exelon. A big issue of caring for people are the so-called neuropsychiatric symptoms. Everybody over time with dementia will get something like depression or agitation or trouble sleeping. These are the neuropsychiatric symptoms. They can be very troubling, and we have pretty effective treatments for them. So part of dementia care nowadays is to treat them. And there are other things that we do, managing comorbidities. We try to prevent delirium, usually by limiting exposure to winter colds or anesthesia and so forth. And very importantly, we help patients and caregivers build a care environment that's successful with dealing with safety issues, helping people, for example, manage their medicines better, not drive if they should stop driving, etc. And we help the caregivers, who are inevitably the partner of the patient in a long illness, be better caregivers in a very practical way. So this is dementia care. I said that it's already available. What's happening right now is that CMS, people who bring you Medicare, have approved something called GUIDE. GUIDE is a nationwide demonstration project that over the next 8 years will provide care management to people with dementia in the community. And the goal is to improve their outcomes, help their caregivers. It's really a care management reimbursement package, which links with the care that's provided by a specialist or a primary care physician in managing the medical side of things. So look for GUIDE to show up. The Hopkins Guide program will launch next July, and certainly Kate and Connie, we would welcome connecting with you to think about how we can get some of your local residents into the Hopkins Guide program when it launches. I keep telling you that dementia care is good for people. So, well, what do I mean by that? Well, let me show you some actual data. First piece of data that we demonstrated close to a decade ago now is that people who get care management at home stay in their home about 12 months longer than if they don't get care management. So raise your hand if you don't like that. Okay, that's what I thought. So care management at home helps you stay at home longer, and we think as care management gets refined, it might actually have greater impact. The second is that we can measure quality of life in the care managed patients to the control patients. And this just gives you a feel here of how in the care coordination, people get better, whereas people in the control, the quality of life gets worse. Additionally, caregivers being such a central piece of this, they actually are able to be more efficient. And over a week's time, they're spending about 12 to 16 hours fewer if they receive care coordination. So they become more efficient, they bring in help, but the caregiver is doing less work when they have care coordination helping them. And that obviously is very important for many, many reasons. And finally, there is a cost savings. We're in a healthcare environment where everybody wants to save money. So doing home-based care coordination, we indicated can certainly reduce expenditures, which is one of the reasons why CMS is doing this. We're not the only ones doing this research, but they have solid reason to think that this care coordination will keep people at home longer, out of nursing homes, out of hospitals, which are not friendly places for people with dementia who don't need to be there, out of emergency departments as well, and perhaps with more activities so that they can be healthier over time. So we've already got this, and it's going to come to a neighborhood near you through this GUIDE project that's slowly building out. So let me take a break and catch my breath and have a drink of water, because now we're going to shift gears and we're going to talk about the MAB. MABs refers to monoclonal antibodies. FDA has now approved two. One is called lecanemab. The other is called donanemab. These basically are designed antibodies. Remember when we created a pet molecule that goes on and does something, sticks and gives you radioactivity? This isn't terribly different from that, where the antibody's job is to go and stick on the amyloid in the brain. Remember, we have this equilibrium from the little stringy A beta all the way to the plaque. So each of them hits a different part of that equilibrium. So donanemab is more on the plaque side, whereas lecanemab is earlier in that whole equilibrium. But they're ultimately, they go and stick on these molecules that are their target. They activate the brain immune system, which then starts removing the amyloid from the brain. And I think this is one of the big successes of pharmaceutical efforts in the US and worldwide, in that they are actually quite successful at removing and reducing the amount of amyloid. So here's what we see, for example, with lecanemab. This is from one of the lecanemab clinical trials. And you can see here, if someone is on placebo and they get an amyloid PET scan, they have sort of areas that are starting to be yellowish at the beginning of the study. These are very mild patients, and we're not seeing the amount of yellow that we saw earlier in an amyloid PET scan. And at 18 months, this grows, and you see more and more yellow distals happening, and the overall background is going more from blue to green. So this is showing that if you don't get lecanemab, you're going to build up more amyloid in your brain. But if you get lecanemab, and this person is starting off worse than this person on placebo. They had more. But look at what happens at 18 months. The amyloid is largely gone, far reduced. This can be quantified as well. So lecanemab is actually quite good, and so is donanemab. Donanemab data are more recent, but if you see patients over time who are on donanemab, you can see that the amyloid is slowly being cleared. And whereas in the control placebo, the amyloid is building up and worsening over time. So they're very good at that. And there's really no discussion or dispute. The question is, how helpful is that for patients? So there's a fairly standard measure called the CDR sum of boxes, clinical dementia rating sum of boxes. And on both these measures, the drugs seem to do better than placebo. So let me walk you through these slides for a moment. So down is worse. This is your clinical measurement. This is a time point. These are the numbers of people at each time point. You see it's months, and they're all about 18-month studies. And if you're on placebo, you follow this black line here. So you steadily get worse over time. You see that on both drugs, the placebo group. Here on lecanemab, well, you see it's a different trajectory. You can quantify that. They say, well, it's 27% slowing. That's basically comparing where you end up at 18 months relative to the pace of change. Whereas donanemab says it's 36% slowing at around the same time frame. But I want you to notice a couple things. First of all, people on the drug are getting worse. No, they're not getting better. They're not stabilizing as a population. There probably are a few people who stabilize or get better, but as a rule, there's progression. So what can be expected is slowing of the pace of progression. How much slowing is this? Well, that's so hard to quantify because these percentages don't mean much to individual people. The typical words that we use is to say, well, think of it over your long illness. This is delaying progression by about, say, 9 months or so, 12 months. So it's a slowing of a slowly progressive condition, and what these drugs can help in that regard. You would then say, well, is donanemab better than lecanemab? Because, well, this says 27% and this says 36%. Well, if you had the right scale for both of these, the same scale, you would see that the placebo groups are very different. So different populations were in the study, and therefore we can't really attribute this 27% or 30%. We can't compare. These are not a good apples to apples comparison. The only way to do that is you have one study with both drugs where you're comparing them head to head in a randomized study. So maybe donanemab is a little bit better. Again, it doesn't totally reverse symptoms, and it doesn't stabilize. So the line is still going down. It's not going up. It's not flattening out. And maybe the gap is widening, but you've lost 100 people, and so it's kind of very hard to know whether this is going to go. But it's promising. And for many of my patients who are eligible, who have very mild cognitive impairment or mild dementia, this can be very helpful. Well, you might say, well, why not give this to everyone? Okay, so maybe it's not that great. And why not give it to everyone? Well, a couple of reasons. One reason is that for these outcomes to happen, you need to be in an infusion center. In the case of lecanemab, twice a month. In the case of donanemab, once a month, and you get the infusion and you go back again in 2 weeks or 1 month, et cetera, for 18 months. That can be fairly intrusive. But, again, if it's going to make a big difference, why not do it? People do this with cancer all the time. And so at one level, it's not so far away from the way we live our lives these days sometimes. So the main reason to be concerned about this are these so-called ARIAs. So ARIA sounds really good. It sounds like something everybody would want, but actually what it refers to is amyloid-related imaging abnormalities. So ARIA is a little bit of a sanitized term for brain swelling on the left here, or brain bleeding on the right, which you see these little black. So people who go on these drugs, because their blood vessels get leaky in the brain, are likely to develop a swelling or a bleed, or both in some instances, called an ARIA. Sorry, it's raining heavily outside my window. I don't know if you're hearing the sound. And so because these swellings on the left, bleedings on the right can lead to bad neurologic events like strokes or worse, we want to make sure that we catch them early so we can do something about them. So when you're getting these medicines right now, you're monitored with an MRI roughly every 3 months. So, and because we're concerned about these happening, especially in the first 6 months, we ask that people not travel too far, because if they get symptoms from an ARIA, we want to be the ones treating them. I don't want my patient who's based in Baltimore to be visiting a child in Wyoming when they start having a headache, and I need to somehow react to find out whether they're having an ARIA or whether we have to treat it, etc. So this is the equation that we have with the mAbs. They remove the amyloid, they bring some clinical benefit, they have this ARIA risk. It's something that needs to be monitored. They have a little bit of a mortality rate. We don't quite know what that is. Maybe it's 1 per 1,000, maybe it's 2 per 1,000. Still something that needs to be figured out. So that's where we are with the new medications, and I wouldn't be surprised if we had questions about them. So what does this tell us about the paradigm? Here we are in a situation where we're taking away the oligomers, but we're really not affecting symptoms. We actually have evidence to suggest we're affecting tangles, maybe neuronal loss. There's some debate about that, because actually brain volume tends to go down with these. So arguably that's not good if you're worried about neuronal loss. And so this might mean a couple of things. One thing it might mean is that we're giving these too late. So that we're giving these drugs right now to people who have MCI or dementia. They've got clinical states that can be diagnosed, and we're giving them to them. Maybe we're too late, and all these other processes downstream have started happening, and even though you can take away the amyloid part, it's kind of like removing cholesterol after you've had a heart attack. It's not really going to make a huge difference to whether you're going to have another heart attack. If that's true, the studies that are ongoing right now, which take older normal people, so really normal people, but who have an abnormal amyloid PET scan, and we give them the drug, perhaps that's early enough so that we can prevent the illness from happening. And there's a little bit of evidence for the donanemab drug that it works better if people have very low or no tau in their brain, suggesting that they are at an earlier phase and donanemab might work better. So that gives encouragement to some to say, okay, this AHEAD study, as it's called, which is finishing enrollment and will report out in 2 to 3 years, AHEAD might come back and say, give them early and they can have a much bigger impact clinically in preventing and delaying. Stay tuned. But the other possibility, there are 2 other possibilities, is that the hypothesis is wrong, and that really what's causing symptoms has very little to do with the oligomers, and we need to be thinking somewhere else in the cascade, or that the hypothesis is partly wrong, and this is where precision medicine comes in. And this is our belief that the pathway to symptoms varies across people, that different people have different pathways. That would mean things like different importance for the A-beta oligomers, different importance for the tangles, and more importantly, maybe there are a variety of other processes, so that the story is a little more complicated. So I've added here the precision medicine idea, which is, well, what about upstream stuff to oligomers? Do your genetics matter to your getting the oligomers to begin with? Can that be mitigated with education or other preventative activities? So there's the upstream question. The other question is, well, does going from A-beta oligomers to tau, is it the same for everybody? Is it all one arrow, or maybe there are different arrows that connect them? And there are other processes like inflammation. We talked about brain perfusion that become important. So maybe people who have bad brain perfusion, who start building up oligomers, have a different pathway than people who have normal brain perfusion who start building up oligomers. that you're really not going to have progress by removing the oligomers unless you fix the brain perfusion as well. So you're starting to appreciate the precision medicine idea, which is what are the pathways to dementia? How do we sort them out? And how do we develop treatments? And that's really effectively the idea that we're starting to use information from many sources to define subgroups or distinct pathways, each of which is going to have its own therapy. So how are we doing it at Hopkins in the Richmond Precision Medicine Center? So we're using something called the Precision Medicine Analytic Platform. That's a huge database that pulls together clinical information, brain imaging, digital brain imaging, lab tests, a variety of other things, and allows us to start thinking in the real world, because these are medical records, whether we can subtype dementia and its associated conditions. So right now at Hopkins, under very tight data privacy control, we have in our Precision Medicine Center medical records from over 700,000 individuals. And we're using analyses of these medical records, and I'll show you a little bit of some examples later on. We are also building a repository of clinical MRI. And the clinical MRI, we are now learning more and more how to read them digitally. So as a first pass, we're planning to use a combination of clinical medical record characteristics and digital findings from MRI on a subset of individuals to start sorting out the different subtypes of pathways of how people get the dementia. Where we eventually want to go is the addition of biologic variables so that we can take blood, and we have the ability now with a single blood extraction to develop, to get DNA, to develop polygenic risk scores, to learn and harvest what are called exosomes. It can take a while to talk about those, but the point is these are pathways eventually to biomarkers and new drug delivery, and especially to stem cells, iPSCs, induced pluripotent stem cells. We'll talk a little bit about those in just a moment, which allow us in the laboratory to grow parts of nerve cells or brains of individuals, and at the individual level to test individual drugs with the prediction as to whether they're likely to help them. Talk a bit more in a second. Just want you to get the first idea. So that eventually we think will bring together the final phenotyping so that we'll know that we have the blue pathway or the green pathway, eventually being able to have the package of treatment for each of these pathways available to individual patients. So what are we doing in specific? Well, we're analyzing the medical records. I'll show you a couple of early wins that we already have from that. We're doing digital analyses of brain images. So these are advanced digital methodologies. So when you get an MRI in the future, it won't simply be the radiologist looking and giving you a reading, but there will be some kind of digital AI processing that will give you information of various kinds. We're developing prediction models. So two general things that patients ask us all the time when they come to us and they get, say, a diagnosis of MCI, Doc, am I going to get dementia and how long is it going to take? So we want to use your existing characteristics to be able to give you an answer. Is it going to be 2 years? It could be 4 years. It could be less than that. Same if you have dementia. Doc, how long is it going to take before I can't take care of myself or worse? So prediction models for prognosis are very important, but we also need prediction models for treatment response. So that we know, for example, that we talked about donepezil, Aricept, and its cousins. There's another medicine called memantine. These are widely used right now. We're quite sure they don't work for everyone, so we want to use prediction models to say this person is a good Aricept candidate, this person is not, the same for Namenda. And by the way, for all of the other medicines that are used, for example, to treat agitation in people with dementia. I'm going to skip over genomics, EVs, and exosomes, a little bit more complicated, but these are other laboratory methodologies. And I'll talk a little bit about stem cells and how they are putting together some interesting platforms for us. So from the real world medical records, as I said, we have people 50 and older who come through Hopkins primary care or through certain Hopkins specialty clinics, including our memory center. These medical records are expanding every month, so there might be new patients coming into the system who are over 70, or people aging into being over 70, and people already in the system have new data. And so every month this data set is expanding. And we've had a number of early wins that we think are sort of very interesting. The one, which was rather unexpected and was published a year ago, suggested that people in the community are being over-replaced with thyroid medicine. So thyroid medicine, thyroid replacement, one of the most commonly used medicines in the aged population. And what we found is there's a subset of people who are getting too much, and that's probably putting them at greater risk for cognitive change. So an example here is of a tangible immediate win is we encourage doctors to measure frequently whether someone in fact needs the actual dose that they're getting or whether they could get away with a lower dose. Similarly, I mentioned to you that vascular insufficiency can affect brain disease. That can tie into blood pressure. And there's this big debate about what's the right blood pressure for a 70, 80, or 90-year-old. And we're trying to answer that question, especially to see what affects dementia risk. In primary care, there's an aggressive effort to keep blood pressure, the top number, at 120 or lower. There's a little bit of evidence to suggest, though, that some people really are optimally treated if they are 140 or lower, and that if you push them to below 120, you might be affecting their brain perfusion and contributing to cognitive decline. So we're trying to sort out for individual people what's the right blood pressure. I mentioned delirium earlier. That's an acute state that people often develop and are hospitalized or develop in the hospital. But delirium is something that is a precursor for dementia in many people. It's a risk factor for dementia. So we're putting together a prediction model in the community to detect someone who's at risk for delirium so that we can prevent it and prevent even a hospitalization and take away the risk of getting dementia that might be coming from delirium. And finally, another early win is I've mentioned the neuropsychiatric symptoms. We've known for a little while that hearing loss and lack of hearing aid use is important to dementia. It seems as though it's especially important to whether people might develop things like agitation or sleep problems, et cetera. So we're actually showing in one of our studies that people who use their hearing aids regularly, who are aged with or without dementia, but who use their hearing aids regularly and properly, are much less likely to develop depression, agitation, anxiety, and similar problems. There's a logic to that. If you can't hear fairly well, you can sort of connect the dots and say, well, yeah, that makes sense. But here's the evidence that we're putting on, which is not just that hearing loss can affect those abilities, but using the hearing aids makes a difference. And that's especially for family members who often bear the brunt of the person with dementia having neuropsychiatric symptoms. All right, I'm realizing it's 3:04, so I'm going to wind down, but I want to show you how we do the digital MRIs. So these are all automated. Some of my colleagues use an automated machine, and you kind of see what the machine does is it breaks the brain down or parcellates it, as it says, into different areas and comes back and gives us a size for each of these areas. Also, there's something called white matter change, and that is important in many ways to cognition and to as an indicator of vascular pathology or that insufficiency that we were talking about before. So again, there are automated methods being developed that we're using primarily in research right now, but hope to use clinically. And there's also a brain stress test that looks at brain perfusion before and after inhaling CO2. Just some examples of the tools we're developing so that we can get more precise in measuring things. So I'll close by going very quickly over stem cells. So these are now human models. Pretty much all the drugs on the market now have come through mice. And we've cured a lot of mice for Alzheimer's disease, but one of the reasons perhaps our drugs aren't that great is that they're not being tested in a human model. So what are stem cells? Well, stem cells are basically cells that built you in your development. When you were an embryo, you were basically all stem cells, and then the different cells in your body differentiated and they became brain cells or muscle cells or heart cells or bone cells, et cetera, et cetera. So now by taking a sample of blood, it's possible to take out of that blood blood cells that are called PBMCs. These are blood cells, but these can be taken out into the lab, and using certain chemicals, they can be reprogrammed to become your own stem cells. So now you have my stem cells in this lab, or Kate's or Connie's, and the lab can now use other techniques to turn those stem cells into specific types of cells related to Alzheimer's. So they can become cortical neurons. They can become neurons that produce serotonin. They can become all these other, including these very interesting three-dimensional little mini brains that are becoming increasingly sophisticated. Well, why is this interesting? This is interesting because depending on the cell that you have in the lab, you can put on it a drug that you know affects that cell. You can measure how that cell is affected by the addition of the drug. And you can then compare people on whether their stem cell, now serotonin neurons, respond to the drug the same way. And we're doing that specifically with two types of marketed drugs. I mentioned memantine, and I'm going to mention SSRIs very briefly. Essentially, I'm just going to skip to the chase here. These are small numbers of people, but this is adding memantine, and I just want you to focus on this. So this is the cells without the memantine, and this is how much calcium they let into the cell. If you add the memantine, you expect the calcium to go up. That's what the drug does. It goes to these cortical neurons and it brings in more calcium. Well, look at this person. It doesn't really seem to do that. And in fact, in this person who starts here, it actually is going down, right? So they start here and it goes down. This person, it's not going up. This person, it is. So this is someone where you would expect memantine to be helpful, and so on and so forth. So the idea is that you have a lab paradigm, you draw the blood, you develop the stem cells, you make the right brain cell, you put the drug on, and you see how the drug reacts in an individual, and it tells you whether that individual is likely to benefit. Same is true for serotonin. So escitalopram, Lexapro, widely used to treat people with dementia for behavioral symptoms like agitation. So here, this is the baseline state before the Lexapro is added. You expect the serotonin to go up, and it does for this person. You know, you add the Lexapro, and the cells are, there's much more serotonin out there. But look at this person. You add the Lexapro, and there's no benefit. On this person, there's a benefit. This person, there's a smaller benefit, et cetera. So the idea here is, this is still early experimental days, but the idea here is that you use these stem cell platforms as a way of deciding what drug to give someone so that you're more precise in using the drug in someone who is likely to benefit. I'm not going to get into the tips for healthy cognitive longevity. Ultimately, it's going to come down to prevention. I can provide this to Kate later on, but I want to really move to my last slide and just summarize what I said to you at the beginning. Dementia is a clinical state. Alzheimer's is a brain disease. Dementia is the next pandemic for the reasons that I showed you. We're very good at diagnosing dementia. Our ability to diagnose cause accurately depends on the biomarkers. We're actually very good now at diagnosing Alzheimer's in living people because we have the right biomarkers. We have pretty effective comprehensive care right now, but not everybody's getting it and not everybody knows about it. The guide model is going to be an approach that will come to a neighborhood near you. The novel medicines are interesting. They're potentially game-changing if they prove to be preventives, but for what we know right now, they're controversial, they carry risks, and so it's a decision about whether or not you want to take them. Prevention is clearly possible. I didn't get into that, but ultimately where this is going is the ability to use better measurement tools, better models, better understanding of people to decide the different pathways to dementia so as to deliver people on different pathways the right treatment. And I will end there, and I will thank you, and I will stop sharing. And now I'm going to need to look at the questions. Are there any villages on the eastern shore of Maryland? I think that's a Connie question. You're on mute.
You're-
You
can't. To my knowledge, no. But the person who would know is Pazita Vive. I can put her email in the chat, Kate, if you don't have it. She knows what's going on in the rest of the state more than I do.
You're mute.
Oh, thank you, Connie. I'll put the resources for the Washington Area Village Exchange, as well as the Village to Village Network, which is the national network that may have a more comprehensive list in addition
Great idea.
to Pazit.
Right. Thank
So
you.
the next question is cognitive decline due to hallucination and vision, hearing, and focusing, which look like cognitive decline by age? No. I need a little more information on fleshing out this, but typically we don't think of hallucinations as something that we would call dementia. And we also don't think of them as normal parts of aging. How is MCI diagnosed? So MCI is diagnosed very similar to dementia. We take a history, we do a physical, we want a history from a family member or an informant, and then we do standardized measures of cognition. The difference with dementia is that we can't give terribly difficult cognitive tests because people fail them. So in MCI, we give more difficult cognitive tests. So the MoCA, for example, that I gave you might or might not be abnormal in MCI. So we usually start with someone, give them the Montreal Cognitive Assessment, but if we strongly suspect MCI, maybe someone who's very accomplished beforehand. So in that case, we need like a 45-minute cognitive battery or more extensive neuropsychological testing to make the diagnosis. But the concept is the same. There are clinical criteria for MCI. So once we have all that information, history, exam, testing, we compare it to the criteria and we conclude whether or not the person has MCI. How good are the outcome measures? How well do they track with real world concerns? And I suspect you're referring to the outcome measures from the clinical trials. And so I'm going to answer for that, but type something in there if I'm wrong. The outcome measures for the biologic variables are quite precise. The outcomes for the clinical measures, well, they actually do look very much like the kinds of things we track in the real world, which is why there is the hesitation to recommend the medicine, since the benefit to real world outcomes is controversial and seems to be very modest.
If you flip over to the chat, Dr. Lacustos, there's a few more over there.
Okay. What testing is already paid for by Medicare? So the clinical piece, the doctor visit or nurse practitioner, the history taking, all that stuff, basic laboratories to rule out a vitamin deficiency, a brain imaging study, typically an MRI, which can include digital quantification of hippocampal size. And for someone with the right story, Medicare will also pay for a PET scan. They are also now paying for the blood tests. I've started using them a little more because I understand them better. So, so testing is Medicare will pay for neuropsychological testing. So pretty much the whole armamentarium at this point. Are high educated and smart people more vulnerable to Alzheimer's? No, if anything, people with less education seem to be more vulnerable. Many ideas about why that can be. Shore does suggest that hearing aids should be covered by Medicare. Well, yes, but Medicare doesn't always make fully rational decisions as to what to cover. We'll leave it at that. Who is eligible to schedule an appointment with the Johns Hopkins Memory Center? Well, let me start by saying we're the only memory center that sees large volumes of people clinically between Philadelphia and Durham. And that goes all the way west to parts of West Virginia and so forth. So we're very, very busy. We'd like to be able to help everyone. And so your question is nicely framed. You know, who is most likely to be helped by what we do? I think I would talk to the primary care physician that you're working with, because it's best that the referrals start with them. And someone where there's a question about whether they have a cognitive disorder that the primary care physician is not able to sort out. If someone is interested, thinks they might have Alzheimer's disease and they want to have one of the MAB therapies that we talked about, that's someone that we should see. You can't really, well, you can get the MABs in other settings, but it's, I would encourage you in these early days of the drug that you be part of a program like ours. And the other big category is sometimes people get very significant neuropsychiatric symptoms. So agitation that's very hard to treat, for example, or a serious sleep problem or hallucinations that were mentioned earlier. I think those are folks where typically primary care docs need our help with. Could speakers send copy of the slides? Yes, Kate's going to do that. We're going to send them to you, but keep in mind that they work best with animation. So you're going to need to use PowerPoint to get the full force. You can get a good sense without PowerPoint. These resources can also provide guidance on starting a new village on the Eastern Shore. Depends on whether lunch is involved. But we're certainly happy to try and help you. Again, let me emphasize that with the MABs, we're incredibly busy right now. We're trying to grow our programs. But we're certainly happy to help guide starting a new village, as we've done that before. Blood bleeds and AD affect treatment how? So I'm wondering if that means brain bleeds. And if it means brain bleeds, then, well, if you get a brain bleed, you've had a stroke. And maybe you just have a small one, but if you have a stroke and you continue on these drugs and the brain bleed came from these drugs, you could die. So we're very, very conservative right now because the drugs aren't cures, and so we don't want to create a much worse situation if we're not careful. Is problems with handwriting a symptom of AD? It can be. We associate problems with handwriting of a certain kind more with Parkinson's disease, but certainly there are changes in voice, intonation, facial expression, other what we call digital biomarkers with AD. Still nothing clean to be able to emphasize.
And back in the Q&A, there's a few more.
Oh, I love this.
Starting with Miss Aarons.
So when you say POW, I'm sorry, I don't remember saying that. I'm not sure.
Oh, yeah,
no,
that one's the first one. Mm-hmm.
Yeah, I did that. Nancy Aarons, okay, Alzheimer's. What is your evaluation of lithium in preventing Alzheimer's? This is a very sophisticated crowd. There's reasonable laboratory evidence in non-human models that it can be helpful to preventing or treating the pathology. The problem is dosing. Lithium can be very toxic, and it's been very difficult to get enough of lithium in the brain to show a benefit, or maybe it doesn't work. There is a company somewhere in the world that has developed a formulation of lithium that can get a lot of lithium into the brain without the peripheral effects. And so that might be the answer, but I don't think we're quite there yet. Can you speak to death? Goodness, for a person with dementia. Well, that's a fair point. We do say Alzheimer's is the fifth leading cause of death in the United States. And the way death comes about is two general pathways. One is by developing vulnerability. So people with dementia become frail. They're prone to falls. They can be overwhelmed by a flu or some other very acute illness that would not affect someone with dementia in the same way. So by becoming frail and disabled, people are vulnerable to more natural, and that's the major way through which people with dementia pass. But some folks, unfortunately, and I've treated many of them over the years, will be in the very late stages. So their brain has declined to the point that they are bedbound, are being fed, don't move much, need to be turned. And that state, I know from personal family experience, someone in the family right now is third year bedbound because she's 97, but is otherwise excellent health. But the person eventually fades away. And the big challenge there is the better the nursing care, the longer they will live. It's one of the real tortures that we sometimes face. There are many TV ads for Prevagen. Yes, although Prevagen is not an FDA-approved medicine and it's supposed to be good for memory, I don't think they can make claims for Alzheimer's disease. Does it work? I don't think so, but I've never seen it studied. So, I tend to be, well, show me. If you think Prevagen really works to treat Alzheimer's, do the study and show me. Until you do, I don't think it works. And remember, for all of these health supplements, we don't really know the risk because they haven't really been studied. We've had horror stories over the years with bad outcomes from some of these. Anonymous attendee, did she mean tau instead of pal? Possibly. So what was the question? Oh, no, tau is a Greek word. It's the letter tau, the Greek letter T, and it's just the name of the protein. I don't know who named it. That's an interesting question. So if you meant tau instead of pal, yes, it's a Greek word. It's not an acronym. How much higher blood pressure has been tolerated? Well, not sure I would quite frame it the way you're framing it. But I think it's the discussion really in an older person, depending on their vascular risk factors, is between 120 and 140. I think it's pretty clear that systolic above 140 and especially above 160 is universally associated with faster cognitive decline. But the one and then below 120 can be harmful to some people. And so the question is, can we find those people and make sure they get a little bit more space? And why is that? Well, that's because as we age, I think that's a pretty universal phenomenon. Our blood vessels become less elastic. And the flow of blood, especially from the larger arteries, depend on the elasticity. It's squeezing and pushing the blood through. That means you need a lower blood pressure. But if you have inelastic blood vessels in the brain, it takes more energy to move the blood flow through. And so that's the concept.
May I ask a clarifying question in that with your response, Dr. Lykestos? Would that be for folks who are medicated to have their blood pressure lowered, or what about those who are naturally low?
I don't think we really know, Kate.
So any low blood pressure could be a risk.
Well, certainly a very low blood pressure could be a risk, but we don't know what that number is. Yeah, so, but you get into the issue is someone who's never been medicated, who now runs a systolic blood pressure of 130. Should they be medicated? Probably, but in every case, I don't know, and that's part of the complexity here. How did I get into this field? Oh, goodness, I forget. Nobody got it.
I don't think we heard you.
Oh, I said I forget.
Oh.
That's a long story. Yeah, um, that's a long story, but it's a good field.
We're just glad you're here.
Has patients' Alzheimer's stage shown improvement? I've had several patients whose blood pressure was overcorrected, and there are clinical indicators that have led me to loosen that. But they're usually cardiovascular indicators, like people feel dizzy or they don't feel right, or their blood pressure drops a lot when they stand up, and it's measured from sitting to standing. So yes, there are people whose cognition will improve if you reduce the blood pressure and give them a little bit more room. I got a ha-ha. And I got a we are laughing. Great. Any study been done to show that? And someone needs to finish her sentence. Let's see. I've got more here. What is the relation of Alzheimer's and pneumonia? Because most of them die by this bacterial infection. Very informative. How about the START trial? Yes. Well, the START trial randomized people to different levels of blood pressure, but had a very unrepresentative population. And they had people with very few vascular risk factors. So I don't know how generalizable the findings are. There's evidence that management to 120 through START reduces dementia, not necessarily MCI. So there's a new START that is being designed to address some of these issues. So yeah, it's part of the information, but it's part of the information that's relevant to maybe 10% of people we see as patients. What is the relation of Alzheimer's and pneumonia? So there's two relationships. So somebody who has early dementia and Alzheimer's pathology in their brain who gets pneumonia might find it harder to recover, more likely to get delirium because they have a vulnerable brain. So that's one, is that pneumonia can exacerbate the cognitive progression, accelerate the functional loss. That's true of any serious infection like urosepsis or severe UTI. I'm not sure that it's accurate that most people from AD who die from a bacterial infection. I think that's probably true for people in the end stages, but not everyone makes it to the end stages. They tend to die from a variety of other things. I'm not a clinician, but I believe the protein tau. Oh, there you go. So I've learned something that I should have known. Tau is named so because it is a tubulin-associated unit. See, being Greek, I always assumed it had to do with the fact that it was a Greek letter. But thank you for teaching me something. What is MAPS? Not sure I know what MAPS is. Someone remember the context?
I did hear something that sounded similar to MAPS throughout. I wonder if it was in the context to the study that you
MABs, M-A-B, MABs, monoclonal antibodies. That's probably what you're thinking of. Yeah. Okay, I'm back to the other. Goodness, there's still a bunch of open.
got them all.
Ha. Thank you. Any study been done to show that has patients' Alzheimer's stage shown improvement if their BP has reduced? We've seen that. Could we get more information on the villages? Sure. That's
Mr. Eastman, where are you from? Are you from Montgomery County or beyond? And that would help me. I'll put the National and the Washington area and the Montgomery, and it's all are great resources. Honey.
I should just say that there is also a group called the Consortium in Montgomery County that is in the early stages of developing a capacity to help villages develop. So stay tuned. it's a little bit like what we've been hearing all the time. This is an in-process event in the state of Maryland. But know that help is available for you wherever you are.
Someone saying, thank you for sharing this information. My father's 95, has been started to show signs. He does not live in Maryland, so he would not be able to come to JHH. Well, I understand that if he can't travel, it'd be very hard to come, but we see people from all over the world. So if he could travel, we'd be happy to see him.
And with that, everybody, thank you. Oh, sorry, Dr. Lacustos, did something else pop in? No, I think we got
No, I was just saying, I think we've done our duty.
We have. Oh my gosh. Perfect timing. 3:31. Thank you all for such wonderful, thoughtful questions and of course, thoughtful responses. Thank you for breaking down this really complicated topic for us, Dr. Lacustos. I hope that we are all leaving here a little more empowered in what we've learned to make the wise decisions for ourselves and for our families. And what we're doing to prevent a pandemic here. So thank you for your work and your lifelong dedication to this cause, Dr. Lacustos, and to Connie for your commitment to aging in place, because that's where we want to be. We want to be in our homes and with our loved ones, feeling independent and engaged with our friends and family. So thank you, everybody.
I'm going to add my thanks for hosting. Thank you.
Of course.
Thank you so much, Kate. But I also want to add that I'm going to make sure to everybody who's listening that we follow up on the suggestion of referring people to your guide demonstration when that becomes available, because I know only too well that it's only through participation in pilot studies like this that
well,
real progress is made.
Sorry to interrupt you, Connie. Guide is not a pilot. Well, I guess I called it a pilot, but it's a real world thing. So yes, I guess it's a pilot technically, but it's supposed to be a real world implementation first phase.
Right, but it's a CMS demonstration, is it not?
Yes, it is. So in that, but I just want to make sure people don't think that it's a research study.
Okay.
That's why I reacted to the word pilot, because many
I'm
times.
sorry. Yes.
No, you didn't say it, but I reacted.
Indeed, we will follow up. Montgomery County and the surrounding areas will be a great source of referrals. We will do our best.
Thank you. We appreciate that.
Yes, and we do have connections in Southern Maryland, including Prince George's, another unfortunately high incidence of dementia. So please continue those connections. We'll help you find folks to participate. So thank you.
Thank you. Thank you all. Take good care.
All right, everybody, take care.
Happy holidays.
Bye.